everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I'm joined with my lovely and talented friends, more talented than we thought before this episode, Carrie Bedient from the Fertility Center of Las Vegas,
Hello.
and Dr. Susan from Texas Fertility Center, who also probably has some talents that I don't know about too.
Hello, how are y'all doing?
Hey, doing great. So we were chit-chatting together among us before we started this episode, and it came out that Carrie had this special talent that we didn't know about. So fill us in, Carrie.
So when I was a kid, I played handbells in the church choir.
I did too.
I
How?
did not. I played my flute at church, though. I did play the flute at church and even played in a wedding one time, actually.
It was actually kind of funny. Like we changed churches when I was in middle school, and I grew up in the Lutheran church, and the church I had been at, I had already done confirmation. And so when we moved, all the other kids were in confirmation and I didn't have anything to do during that time. So I joined the handbell choir. And so I was in it until I graduated high school. And they actually played at my wedding. Like instead of
that's really cool.
I had handbells at my wedding.
That is really cool, Susan. I love that.
That's awesome. I had a handbell choir at my wedding too. So by the time I got to, let me think about this. I started when I was 8, and by the time I got to high school, the director was like, you need to be in a different choir. And so he called around, found auditions.
Oh my.
And there's a performance choir that was in Phoenix at the time. And so I auditioned and got in, and we played with the Phoenix Symphony, and we toured in Japan and Puerto Rico.
You toured in Japan? How did we
all
not
over the
ever know this,
country.
Carrie? We've known you for 4 years. How do we not know you toured in Japan?
We played a lot of expositions, and it was probably, there were like 14 or 15 teenagers, and we had a huge set. It was like 7 or 8 octaves. So the bells that are, just absolutely huge, where you have to lift with 2 hands. And then all of the teeny tiny bells, like I typically played at the top of the range. So if you had the top of the range, you would play an entire octave all at once. And so like do 6 in hand and, all of that stuff. It was a lot of fun. And that performance choir came and played at my wedding.
That is so cool. How very neat.
That is neat.
It was fun. Yay.
Well, I did play in a flute wind ensemble, sort of thinking about the same instrument. We had a piccolo, a C flute, a few alto flutes, and a bass flute that actually curves around. And we actually, we didn't tour in Japan or anything, but we did go around locally and play when I was in college. So that was kind of fun.
What other instruments do you guys play, or did play at some point?
At one point I played the piano. Just piano and flute are my only two.
What about you, Carrie?
I started off on piano, then picked up bells, then did flute, then did oboe.
Wow.
And sang.
I did French horn.
Nice.
And what about you? Would you say horn?
French
horn. That's right. You said you told us you played French horn. Wow. Pretty cool.
Nice.
How fun. So another fun thing we're going to do today is talk about PCOS. And we're actually going to do a question episode. And Susan is pulling up some questions as we speak right now.
I do.
Susan, do you think this is our biggest question bank at any given point in time? Like if you kind of think about all the questions we get, because we put them all together in various topics so we can track. Is PCOS pretty much always the big one?
I would say the biggest is failed IVF cycles.
Okay.
And I would say PCOS is probably in the top 3.
Okay.
Yeah.
Nice.
Good stuff. All right, here's our first one. Hi, do you have any experience of patients bleeding heavily after trigger shot? It has been, this has happened to me 2 cycles in a row, 16 hours after Ovulation. I had a miscarriage late, 9 weeks, but had saline that was looking okay, doing letrozole stimulation due to lean PCOS. Makes me sad that my body seems to be actively working against me by being so counterproductive. Second question, do you recommend inositol and metformin for women with lean PCOS, BMI 20, so weight loss is not on the table?
There's a lot of layers to that question.
Yeah, a lot of different areas to cover.
Yeah. Let's start with the bleeding after trigger. So I don't know that I have seen this, and it sounds like it's heavy bleeding. It sounds like this is not just a little bit of spotting. Did you guys read that the same way?
Yeah.
That's what I thought too.
So whenever I see heavy bleeding in the middle of a cycle, that makes me think you didn't necessarily have a really thin lining when you started. And so this would be a case where I would go in with a hysteroscopy. I would make sure that there's not something structural there.
Yeah, that's what I thought too.
Also make sure that the lining is legitimately thin, because sometimes we'll start people when they've got, a 5-6 millimeter lining, and you may be someone where they actually need to go through and take it all the way down so that it's truly got a chance to regenerate and grow. Because I was worried that the lining is unstable. So you've got, the first 3-4 stories of that building that are stable enough, but by the time you get to stories 5, 6, 7, and 8, they stopped putting in beams to hold it up, and so it's been held up by drywall.
The Jenga puzzle is falling down.
The Jenga puzzle is falling down. Like the floors are starting to collapse on each other, and it's not ideal.
And the other reason hormonally that could be the case too, because we all know that's right when the estrogen level starts to drop, and when any drop in hormones can sometimes trigger people to bleed. And so I'm kind of like you. I think she must have started out with a much thicker endometrium, and then when the estrogen dropped, that just sort of triggered her to start bleeding. And sometimes with PCOS too, when you start bleeding, it just keeps going and going and gets worse and worse as your uterus contracts and you cramp and all that. So yeah, I think it's more related to the thickness of the start of the endometrium, but it could be a polyp as well.
Yeah, I totally agree with that. And then I also, in regards to the inositol and metformin, big fan of the inositols. I would say absolutely make sure you're taking your inositols. Metformin, if you're lean PCOS with evidence of insulin resistance, like an elevated hemoglobin A1C, then I would probably use metformin. I'm not a huge metformin fan in the absence of elevated hemoglobin A1Cs, just because people just don't tolerate it that much. And I think the inositols kind of act almost more on a systemic basis than the metformin seems to.
Well, and typically thin PCOS patients, usually if you look at fasting glucose and insulin, I rarely see anybody that has an abnormal fasting insulin or glucose.
There's still a than the average population.
Yeah, I agree with that. But just as a general rule, if somebody came to me on metformin and was having problems with it, I would say back off to whatever dose you can tolerate. And then, it may even be worth stopping or decreasing the dose you're on and checking glucose and insulin or hemoglobin A1C or whatever you want to do and just see if there's a problem there or not, if you really need to be on it or not.
And talking with a medical endocrinologist relatively recently, they were saying, like, look, sometimes you need the higher doses of metformin if you can tolerate them, but you see the most benefit in the first 500 milligrams. And so
really? Huh. I didn't know that.
If you can't tolerate up to 1,000 or 1,500 or whatever, just get the first 500.
Well, and I usually say titrate to what you can tolerate. I didn't really realize that, but I mean, little's better than none at all if you really need it. So, and generally people can titrate and figure out what dose they can tolerate. Most people can tolerate some dose of it.
All right, here's our next one. Hello, and thank you for your podcast. I've learned so much from it. Thank you for listening. I'm a 21-year-old female with long and irregular periods, BMI 25, but gained 20 pounds in 9 months. I went to see my OB-GYN with concerns of PCOS, and they ordered an LH and FSH level on cycle day 41. My LH was 21.9 and FSH was 8.3. When discussing these results, I asked my provider if we could do further testing, such as blood work and ultrasound, to determine if I have PCOS. They stated that the lab results we already had done, LH and FSH, were indicative of PCOS and other testing would be unnecessary. When asking about an ultrasound, I was told that these are no longer done in the US to diagnose PCOS. I am feeling overwhelmed and discouraged. What steps should I take next? I would say find another doctor, but y'all can be more specific. I think
a second opinion is reasonable here.
It sounds like a provider that's going by an old criteria, because we used to look at FSH-LH ratio, and that's kind of what they're going by, I think. So I think they're actually not up to date on what we actually use as the criteria for PCOS now.
Let's
Yeah.
kind of review what are the basic criteria of PCOS.
So Rotterdam criteria, which is what most of us are going by, looks at three things. It looks like it looks at a follicle number on ultrasound being pretty high. It looks at irregular cycles, which you hit that criteria just with your story
Definitely.
already. And then the other thing is it looks at any sign of hyperandrogenism, so elevated male hormone levels, because both men and women have the same hormones. It's just you have them in different relative amounts. Women have way more of the estrogens, men have way more of the androgens. And so even a relatively very small increase in androgens, the male ones, in a woman can have an effect, whether that's hair where you don't want it, acne, blood work that shows higher levels. Any of those things are fair game to make the diagnosis, because some women are more sensitive to the hormones and it shows up in a way that you can see, and others are not so much and it may not show up in a way that you can see. So we're looking for at least 2 out of the 3 of those. And so you at least have one. Usually I would say that the androgens are the next easy to pick up because, and this isn't a totally fair thing, but if you ask any woman, hey, do you have hair where you don't want it? Do you have acne? The answer is almost always yes. And
Yes.
ethnicity plays a little bit of a role in that.
Mhm.
The standards for someone who is of East Asian descent are very different than someone who is of maybe Mediterranean descent.
Mhm.
But that's kind of the quick criteria that we use when we're trying to figure this out. So you don't need a whole lot in the way of labs, but I do think it's probably reasonable to get like a testosterone level and look a
Mhm.
little deeper.
But PCOS is also a diagnosis of exclusion. So it is appropriate when you're about to get a diagnosis of PCOS to have your thyroid checked, check your
Mm-hmm.
prolactin, check
Yep.
um, for your 17-hydroxyprogesterone, and see what your DHES and your testosterone levels are, because there are weird things that can happen. Okay.
Mhm.
It
That's a great point, Susan. That happened to me with somebody this week. That's a very good point. I found somebody that had a really off the charts prolactin level when
mhm.
she was acting like a
Yep.
PCOS patient. So that's a great point.
Yeah,
Yeah.
and so it is important for you to have more of an evaluation than you've had, and so I do commend you for being on top of things, and I would probably go get another opinion.
Yeah. And you're 21, which means like this is all young enough that some of this stuff you may have never been to a doctor to even talk about before, to maybe go back in your history from the time that you were, 14 to 21 and realize, oh, some of the stuff that I was going through is maybe not necessarily normal where I thought it was, because you just don't
Yeah.
have the life experience to know that that's not necessarily normal.
Absolutely. Good stuff. All right, our next one. Thank you so much for your podcast. It's helped me so much on our try to conceive journey. I have PCOS and subclinical hypothyroidism. Husband has no known issues except for a slightly lower sperm counts of 10 to 15 million. Our egg retrieval, we had 39 retrieved, 27 mature, 19 fertilized, 3 blasts, 3 sent for PGT testing, 1 abnormal, and 2 inconclusive. We just
Oh, yuck.
we
That's
just
So
awful.
completed our
annoying.
first FET, which failed.
Oh.
Is there anything I should consider testing before moving forward with our next FET? Retest our 1 inconclusive. I feel my egg quality is our main battle, especially going from 19 fert to just 3 blasts. If we need another egg retrieval, is there anything that can be added to my protocol or prep to help? We've been trying to conceive for 7 years with no positive. I'm 34, he's 35.
And the one thing that jumps out is she had 39 eggs and 19 fertilized. I don't know how many. Did she say how many did they did ICSI on?
27 were mature.
Oh, 27 mature. But definitely one of the things, and this may not be the whole issue, but one of the things that would be potentially helpful is to do something to help with maturity. And that's the big challenge you have with people with PCOS. A lot of times, in fact, when I see people that have over 20 plus eggs, I usually tell them just be prepared. A lot of these are, there's sort of a sweet spot, I think, in terms of the number of eggs that you produce with an egg retrieval. And sometimes if you have a really high number of eggs, sometimes those are the people that have the poorest development of the eggs. It's almost like your body just can't make a good number of eggs or really high number of eggs well. So in terms of the stimulation, what I would focus on is 2 things. I would focus on maybe not stimulating her as hard so that she doesn't make as many eggs, but hopefully see if you can do some things to improve quality. Um, You may want to think about adding Menopur in there to help with maturity a little bit. You might even want to think about growth hormone too to maybe help with development of the eggs. But those are the things that I would think about in terms of actual stimulation.
So one thing that I see that I mean, if you have 27 mature and 19 fertilized, I'm not super concerned about that. That's still more than the average person is going to get.
Good
But
point. Yeah.
that drop from 19 to 3 blasts, I know we don't all kind of agree on DNA fragmentation of sperm, but if you haven't had that checked, you might want to see if that is checked. I mean, we do tend to blame most things on eggs, but we also know that sperm can play a factor in this, and it might be something to check out just to leave, no stone unturned. But really, I think trying again and maybe discussing with your clinic if there are other options for maybe other labs to do your PGT testing. Um, if I only have one inconclusive, some of that's going to depend on if you want to take the risk of rebiopsying or not. I usually tend to want to rebiopsy if I have multiple to rebiopsy, or if I have a whole lot of abnormals. I recently had a patient and she's in her early 40s, who we biopsied like 11 embryos. We ended up with one normal and one that was inconclusive, and the rest were abnormal. That's somebody I encourage to do the testing, because odds are it is abnormal, and I didn't want her to use up benefits to go and do an embryo transfer on an embryo that's got a more than 50% chance of being abnormal.
When I think about these numbers, I think 39 to 27 in a PCOS patient, particularly if you have a doc who goes for absolutely every little follicle, that may be totally normal. And so I don't know that I would worry about that so much. Your doc can shed some light on how many did they expect to get, because that context is important. If they expected to get 50 and they got 39 with 27 normal, that's very different than if they only expected to get like 30 and they got 27 that are mature. The 19 fertilized, that's a little bit lower than I would have expected. It's still a lot, but it also says something about the quality. And so I do think that the sperm testing is worthwhile to do. The going down to 3 depends on partly how your lab looks at things. Getting 2 inconclusive out of the same batch, that's not unheard of by any stretch of the imagination, but it does make me really curious as to what type of PGT is being done. Is it just looking at the words have fallen on my brain. Is it looking at SNPs? Is it looking at NGS? Is it like what is the actual technique being used? It also makes me wonder if they needed to be more aggressive in the biopsy to send them off. And there's so many ways that you can get inconclusive results. It doesn't mean that anybody did anything wrong. It's just, it kind of makes you think
it's a hard thing to do. It's not easy to do that.
It's not easy to do that. And the other thing that I'm kind of curious of is what happened to, like, where did the development fall off between those 19 and those 3? Because there's a big difference in how we look at it. Because
were they multi-cells, or were they early blasts that were poor quality type of thing? That
exactly,
makes sense.
because if everything hit day 3 and developed normally and then just never progressed, we think about that a little differently than something where you made a ton of blasts, they were all just really not good. And so I'd be curious about that, because we see a lot of patients, at least in our clinic, where they make the appropriate percentage of blasts. It's just most of them are crappy, and not going to go the distance. And so that's why we don't take them further. But that's different than when someone doesn't have anything progress past the multi-cell stage.
And what would you do differently if you knew that?
I would think more sperm if it stopped at the multi-cell stage versus more egg if it kept on going. They were just crappy embryos.
Yeah.
So you're thinking potentially if she wanted to use donor eggs or donor sperm, you'd have sort of a way to figure out potentially which one it could be.
Or what more to target? Do I pay for DNA fragmentation testing of sperm, or do I pay for growth hormone to help the egg? Or do I, if it's kind of a split, do I just kind of hit everything all at once?
Mm-hmm. Yeah. And it gives me a little bit more faith to do, like if you've got a bunch of embryos that made it, that gives me a lot more faith of keep trying. Eventually you'll get there versus ones that just never make it that far where I'm maybe a little bit more guarded.
So I'm
And
going off on a little bit of a tangent. Would this be somebody you want to do PGTA plus in?
yeah.
Yeah.
Give you a better sense of egg or sperm or
So PGTA plus is going to give you information on the abnormal embryos as to the source of the abnormality, whether the abnormality came from the egg, the sperm, or the embryo itself. And so that kind of gives us an idea if you're doing a second cycle, what more do we need to target as kind of figuring out the implicator other than just PCOS going on. Good idea.
Okay.
All right, ready for our next one?
Yes, let's do it.
I was diagnosed with PCOS at age 16 and was put on the depot shot and metformin. At age 17, I stopped taking both because I was told I did not have PCOS by a different doctor. Now, age 22, my husband and I have been trying for a baby for 3 years. I went to a different OB-GYN who did blood work and said I was not showing signs of insulin resistance, but ordered an ultrasound and saw my string of pearls. My cycles are
not the ones around her neck, I'm thinking.
not the ones around her neck. My cycles are typically 41 plus days, so I was told that I am not ovulating. Instead of putting me on metformin, she put me on myoinositol and told me to come back when I'm pregnant. Is this a good alternative to metformin? I am also working with a dietitian to lose weight, but with no luck. Is there anything else I could do to start ovulating? This is a great question.
Lots of layers. One thing I would just say, she's been kind of at this since 16 and 17. They did something else in 22. The one thing I think people may not realize about PCOS is some people are born with it. You can be thin, you can have PCOS, you can be heavy, you can have PCOS, but there's also some people that acquire it essentially, almost like diabetes. It's like if you gain weight, and she mentioned she was trying to lose weight. So, and some people, if you gain as little as 8 or 10 pounds, that can kind of tip you over the edge and just change you hormonally where you have PCOS. So you may have been somebody, maybe at one point you had it, maybe then you didn't, and maybe now you have it because you gained some weight. So I think that's an important point to make about PCOS.
Yeah, as to the question about inositols and metformin. So metformin is moderately good at helping you have regular monthly menstrual cycles. It does not substantially increase pregnancy rates. Okay, it's good as an adjunct, not usually a good single modality to get you pregnant. When it comes to inositols, if somebody wants to do things like uber naturally, I'll sometimes give them a few month trial of inositols if they're young and are like, I really don't want to do anything more than this at this moment in time. I think it's reasonable to try that for 3 to 4 months. I wouldn't try it on its own indefinitely. Okay. And you may need a little whiff of letrozole or Femara, an oral medication that'll help your brain and your ovaries talk more effectively. And I think that's a reasonable next step considering kind of your whole scenario.
I think looking at exercise too, even just starting exercise, if you do not see any change on the scale, can make a difference because it improves your insulin sensitivity. And so I didn't see much discussion about weight or weight gain or weight change. But that may be something that has a bit of an impact, losing even just 5% of your body weight. It doesn't have to be a whole hell of a lot, can make a difference there. So that may be something to think about as well.
I think
Well, one of the things, go ahead.
I think another big thing, kind of what Abby was getting to, you said you were diagnosed with PCOS at age 16. If you started your periods, say at 12, and say maybe 12 to 15, they were normal, happening every month. And maybe as we got in our teenage years, we started gaining weight. And that's when we started getting PCOS symptoms of their irregular periods and things like that. Or if you were that person who, from the first time you had your period and then you didn't have another one for 3 or 4 months and that kept on repetitively happening, People who are always irregular, I think, are less likely to become regular with weight loss, though it is going to give you better pregnancy outcomes. Okay. But if you're always irregular versus somebody who may have had kind of that weight induced PCOS is something to look at when you're looking at your big picture as well.
One comment I was going to make about what you said about metformin and induction ovulation, there are very few things in the field of reproductive medicine that have been looked at with randomized prospective data, and that's one of the few that has actually been looked at. They looked at, whether metformin by itself versus ovulation and drugs induced ovulation, and they showed that metformin might be helpful, but it's not the whole story, and you really shouldn't rely on it to be the thing that actually induces ovulation. You should rely on either letrozole or clomiphene, basically.
Perfect. All right. This one comes all the way from Australia. Thank you for our
Wow,
overseas
down
listeners.
under.
Absolutely. Thank you for the wonderful podcast. I'm 31, trying to conceive for 5 months. Been diagnosed with PCOS with the two criteria: irregular periods every 30 to 45 days, and positive findings on ultrasound, AMH 52 picomoles
Wow.
per liter.
Oh, different, yeah.
Different units of measurements than we usually use. I am certain I am not always ovulating. She's using OPKs. However, all my hormone levels are within normal limits: FSH, LH, estradiol, progesterone, free testosterone, sex hormone, binding globulin, DHEAS, hemoglobin A1C, fasting glucose, all normal.
Wow.
I don't have the typical androgen excess or metabolic phenotype. She's 48 kilos. Question: is it common for PCOS without excess androgen on bloods? Would metformin still help me even without the androgen metabolic phenotype? Can you talk a bit about lean PCOS? We've been having a lot of lean PCOS questions this time.
Yeah. I would say, and I ask an endocrinologist this question, if somebody doesn't have elevated insulin, is metformin going to be helpful? And they're like, no, it's not going to help if you don't have that problem. So the answer is kind of no. It probably won't help if you're lean PCOS and you don't have elevated insulin, I think.
But I do think that that having people with PCOS without androgen excess, there's a reason why it's 2 out of 3. Okay. Because there's enough people out there that don't have
Yeah.
that evidence of androgen excess, that just having irregular periods and just having, the ovaries that appear polycystic on ultrasound, that they meet the criteria and they follow it. I always think of, not only as PCOS polycystic ovarian syndrome, which means it's a constellation of symptoms that tends to have things in common, but it's a spectrum. Okay. I mean, you've got people who I'm like, oh, you're like going to be an easy PCOS person. And then there's
Yeah.
other
Some
people
people that you're like,
who we look at and we're like, ooh, this one's going to be a challenge, and this one's going to be a challenge. Their ovaries are quite enlarged. There's like a bajillion follicles. I mean, everybody with PCOS has a lot, but there are some people who have a whole lot. And
Yeah.
and those are the ones. I mean, it's just kind of like when you're talking about type 1 diabetes, you have some people who are easier to control, and then there's people who are very brittle. I think there's like a brittle PCOS person too. So
yes.
it all goes together.
Sorry, Carrie, I didn't let you talk. I was going to add one more thing, but you go ahead.
No, go ahead. Go ahead.
I was just going to say, I Googled 48 kilos, which is 105 pounds. And so she's, by our American standards, I don't know how tall she is, but that's pretty small person. And, definitely we have patients with thin PCOS. But the one thing when I have med students and residents that follow me around, I always make the case that when you see a patient who you think has PCOS but is very thin, you should at least entertain the idea that maybe it's not PCOS. Maybe it's somebody that actually has that other condition we've talked about before, the athlete's triad, that is a thin person who has sort of a stressful life, who really is in a calorie deficit, and therefore they stop, ovulating regularly. Now, I think you probably do have PCOS, but the one thing I would say is, the other thing that I think trips up even clinicians sometimes is they look on ultrasound and they're like, oh my gosh, this 25-year-old or 31-year-old has just gazillions of follicles on their ovaries. Well, I mean, people with hypothalamic amenorrhea are otherwise fertile and their ovaries are good. They have a gazillion eggs on their ovaries many times too.
Mhm.
So sometimes it can be a little tricky to distinguish between the two. And just kind of wanted to throw that out there for people who may be listening who have been told that they have thin PCOS. It may be something different.
Absolutely. All right. This next question. Hi, I read on PubMed that women with PCOS who are trying to get pregnant often have success with IUI rather than IVF. Unfortunately, I didn't find any rationale why that's the case. Can you please tell me the science behind IUI, which has much lower success rate than IVF typically, and why it's successful for women with PCOS?
So part of the main fertility issue with women who have PCOS is that they're not ovulating. And that by itself is very different than kind of all comers to fertility, where you've got people who don't ovulate right next to people um, who have terrible sperm levels, who have a uterine abnormality, who have tubal problems, who have this or that, the other thing, or most commonly, a little bit of a bunch of things. And so when you have someone who is just a straight PCOS patient, you tend to have a cleaner shot at getting pregnant with IUI. Now, the frame of reference is that all comers trying to get pregnant in someone who's under 35, it's about 20% per month, maybe 25% if you are absolutely ideal in every respect. And so with PCOS patients, if there's nothing else going on and you can do an IUI cycle, which is pretty much always going to be done with Clomid or letrozole, ideally letrozole in a PCOS patient population, then you've got a decent chance of it working compared to someone who is insisting on doing IUI, even though their partner sperm count is 500,000. And so there's, to some degree, that is part of what's going on because it's just a much, from a data perspective, a much cleaner population to work with because you got the one problem, not necessarily all the others. And so you're a little more likely for it to work.
And you're fixing that one problem.
And you're
Right.
actually fixing and addressing that one problem.
But
Always important.
But I want to be clear that with today's success rates of IVF, and in most of our laboratories, we're going to have a 60 to 70% chance of taking home a baby with a transfer of a chromosomally normal embryo in a woman who's under 35, dot, dot, dot. You're never going to get that success rate from an IUI cycle with ovulation induction. And so it may be that they're promoting ovulation induction with IUI as a first step that is very, very reasonable because of people to be successful, you're at the top of the list versus truly a higher percentage of success because no one's going to get a 60 or 70% chance of success with IUI.
No, but if you fix that one problem and it's additive and you say it's additive for, I don't know, 3 or 4 months, you're right. You won't get to that, but you will get a pretty good, I mean, if that's really the only problem, then you'll still have a pretty decent chance of getting pregnant over a 3 to 4 month window.
Right. You'll have a great shot, but I just wanted to be clear for our listeners not being able
That
to,
IVF
not
is,
knowing exactly what this was read on PubMed, that those success rates are never going to be equal.
I wonder if they're talking about if you've got somebody who's like in their 43, 44, 45-year age range where IVF really isn't wildly successful, but you still have somebody who's got follicles. I wonder if
that's a microcosm of the population.
Well, yeah, but if that's her, that's 100% of her.
How old is she?
I don't think.
Did she say how old she was?
I don't think she said.
I think she said.
Oh,
no.
okay.
Yeah. Okay.
Okay.
All right. Our next one. Hello, my husband, 43, and I, 39, have been trying to get pregnant for 2 years. I've had hormone issues my whole life. I had GHD, childhood onset, and in my early 20s, my heavy periods stopped without explanation. I was put on birth control pills to regulate and was on it until I was married. I have hypothyroidism and have always been overweight, ranging from 170 to 190. She's 5'3". My endocrinologist says, based on my blood tests, I do not have PCOS, no levels of testosterone, DHEA low. My fertility clinic says I likely have it due to my AMH being 3.66 to 4.08. No evidence on ultrasound. Put me on metformin. We'll likely be using IVF once we get my husband's sperm sample. But how can one doctor say I definitely don't have PCOS and the other one does? Thanks.
that's because we try and put PCOS in a perfect little box. And as you alluded to before, Susan, not everybody fits in that perfect little box. I kind of think you probably do have PCOS because most women at 39 don't have AMHs of 3.6. So I think, even though that's not truly part of the criteria, I kind of think you probably do have PCOS. My argument at this point would be that's a little bit of a moot point because I think at 39, the bigger issue is you're 39 and, you probably want to do something. If you've been trying now for 2 years, if I was seeing you, I would be really trying to talk to you about doing IVF, and you would be a great candidate for IVF because you do have a good AMH. And so I always say it's like buying lottery tickets. The more lottery tickets you have, the more chances you have to win. The more eggs you have at 39, the more chances we have of finding one that's normal. So I personally would not get real caught up on that diagnosis. I would get more caught up on, I want to have a baby and I've been trying for 2 years and I'm 39. And I would say, I would recommend that you go to IVF sooner rather than later, and you have a good shot at it.
There's some people who, when they get their PCOS diagnosis or when they come to us, they're in their late 30s. And at that point, all their numbers are pretty unremarkable. I mean, in the sense of an AMH of 3.6 at age 39 is remarkable because it's high, but it's also not a standout level by itself because we see levels that are 3 across the spectrum all the time.
But at 39, though, it would be.
But at 39, it's a lot higher. But it kind of makes me wonder, like, okay, did you have an AMH of 10 at one point, and now you're 39 and it's down to 3, and you've got a history of irregular periods and, kind of the carrying more weight, and just the whole picture altogether makes me wonder, maybe you were PCOS fitting the classic criteria, 5 years ago, but you were still on birth control pills. And so you didn't actually know it. And would also agree, the diagnosis is kind of irrelevant, just irrelevant. Just like go for the solution and nail it.
I think this brings up a good point, though, that when you are managing PCOS when you're trying to get pregnant versus when you're not trying to get pregnant are two very different things. Okay. So strictly speaking, when we're trying to help you get pregnant at this point in time, PCOS actually puts you in favor because although you're getting older, so we're worried about quality, you have a higher quantity than the average person your age. So that's great. Okay. And that's from your REI's perspective. When you're looking at your medical endocrinologist perspective, they care about you getting pregnant, but really what they're looking at is your long-term health and well-being. And we know that women with PCOS, whether they are lean or obese PCOS, now obese PCOS, you're going to be at even higher risk than all these things. Your risk of getting diabetes, high blood pressure, heart disease, stroke, all of those things are going to be higher than the general population. And adding obesity on top of that is going to make it more difficult. But realize that these two different sets of doctors, though they both have training and expertise in PCOS, they're not necessarily coming at it from the same vantage point.
All right. Well, this has been a great episode. Is there anything else, any words of wisdom you guys would like to add in?
Just if you think you have PCOS, go see a reproductive endocrinologist, because even though we've talked about all these different types of PCOS, the thing that actually breaks our heart the most is when people come in and they've been told for years they have PCOS because they've had absent periods, and come to find out they actually have diminished ovarian reserve. And so really take that next step to make sure, hey, I have PCOS. That's okay. It's how I'm wired. We're going to work with it. We're going to get me healthy. We're going to do all those things and kind of lay away those concerns of maybe I'm having those irregular periods because I actually don't have many eggs.
The other thing is to let go of some of the anger and frustration with primary, OBGYNs, where we have a lot of people who come in and say, all I wanted to do is put me on birth control pills, because PCOS, the way that we deal with it is we address the problem that the patient's having, because we don't expect to cure it. We just want to try and help with whatever problem is most pressing, whether that's crazy irregular periods that are super heavy when they do come, or an inability to get pregnant. So it's very possible that at other stages in your life, when you were at your gynecologist, the appropriate thing to do is to give birth control pills because you weren't trying to get pregnant at that point. And that is the best way to protect you against endometrial cancers and all these other bad things that can happen. It's just not the approach now when you're actively trying to get pregnant. So if you can kind of let go of some of that anger,
Good point.
that can be helpful.
Yeah, I think as physicians, we all want to do the right thing by our patients. And I don't think anybody goes into this trying to do something that's going to frustrate you or upset you. And I think that's a great point, Carrie, that when you started out, birth control pills were appropriate. But, as you got closer to reproductive age and wanted to have children, it is better to switch you to something different. So, all right. Well, great episode to our audience. Thanks for listening. Tune in next week for more. Be sure to subscribe and leave a review in iTunes. We'd love to hear from you. We also love your comments and your show ideas.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're thinking and want to hear.
And always remember, this podcast is intended for entertainment, and make sure that you ask your own specific doctor on your own specific questions. All right, guys, have a wonderful rest of your week, and we will talk to you soon.
Bye.
Bye, everybody. Thanks.
Bye.